Ford, I want to appreciate you taking the time to be with me today and look at this program, Gum Disease in Your Heart, a Collaborative Opportunity. I'd like to start the PowerPoint, and I'll have you introduce the program.
Great. I appreciate you doing it too, Doug. I know you'll be providing this to your community, and I'm clearly going to provide it to mine. Doug Thompson is a dentist that I've worked with for a few years. He started the Wellness Dentistry Network. So what we're going to talk about today is gum disease and cardiovascular inflammation. We'll talk about inflammation in several different places. One of the things we'll talk about is how, yes, you can see, when you start looking in the science, you can see that gum disease does cause heart attacks. We'll get into that. We'll talk a little bit about the communities and why Doug started that Wellness Dentistry Network. And then we can talk about what you can do for yourself to understand, do I have cardiovascular inflammation? Am I at risk for heart attack and stroke and other diseases like dementia? And what can I do about it? So Doug, take it away.
Yeah, thanks so much, Ford. It's interesting because in dentistry, we had to, in our earlier dentistry efforts, as far as gum disease, and what I mean by gum disease is, I mean this disease here that you can see, where you can see the bone has been eaten away and the teeth are showing. What we learned about with that gum disease is that gum disease we typically thought it was just a disease of the teeth, and it just affected the teeth. But now we know, after all the science has come out, that gum disease is initiated by bacteria, and these bacteria live down around the teeth, but these bacteria are now responsible for up to 56 other systemic diseases, and or they either have an associative risk or they relate in some way, shape, or form. And vascular disease is one of the big ones, and that's how you and I got together and started to talk about how we could collaborate and help each of our respective communities, learn more about that and what that means to us. So,
hey Doug, do you mind if I interrupt for a second and make a couple?
Whenever you want.
So, speaking of the science, I just wanted to make a couple of comments. There have been public health billboards and information out for decades regarding dental health, oral health, and the connection between heart attack and stroke. There have been a lot of folks that are skeptics or have been skeptics. We mentioned our friends and mentors, Brad and Amy and David Vigorist. David's a great, well-trained genetic lab guy from Vanderbilt, works in my genetics. The three of them, Dave, Brad, and Amy, published an article recently that I think puts the last nail in the coffin for the doubters that are saying, is oral health really related to heart attack and stroke? And the answer is yes. That article was covered by John Lorscheider on our channel. So I'll put that link under this for the folks that are looking at this on our YouTube channel. Up until then, there was still very, very strong evidence. And one thing that many people don't know is there have actually been studies where they took heart attack victims. They took the clot when they did the angiogram or the angiography and the procedure to help get the clot out to treat the heart attack. They actually looked at those clots, cultured them, looked at the gum infection, and found the same bacteria in over half of the clots. So those of you who think that this may not be a real connection, go back and look at the science. It's there, and I don't think anybody's arguing it anymore.
Yeah, and I think, Ford, to that point, this is what's happening in our literature. We're continuing to get these science articles about how periodontal disease is not just confined to the teeth, but is starting to affect all these other areas of the body. We know that probably more than 50% of the Americans have some kind of issue. It can be up to 70%, depends on what studies you look at. 10% have severe disease. And so we know that this disease travels around. And in dentistry, we can do a much better job treating the disease. But it starts with early disease identification, because it used to be really easy in my practice to see who had periodontal disease, because they would have either loose teeth or they would have large amount of root showing, and it would be really easy to see. But now, if we're starting to look closer, we want to get to the disease really, really early. A lot like what you're trying to do in vascular disease. I mean, you're not waiting for people to have a heart attack or a stroke. You're trying to use other ultrasound images and inflammatory biomarkers, and you're trying to figure out who's at risk, and then giving them some ability to change that well before it becomes a problem. And in fact, since we know that this periodontal disease is tied to these 56, 57 other disease entities, and that everybody's different, we have entered this era of what we call basically periodontal medicine. But the periodontal medicine, we want it to be preventative. And so we've added another kind of a P, if you will, to periodontal disease, and that each one of these infections are really personalized. These infections are personalized, and what makes the personalization of a gum disease infection is the kind of bacteria they have in their mouth, coupled with their own associative risk factors. So it's their risk factors, both their genetics and how they live, that determines how they respond to these bacteria. So we have this personalization of the disease. It's precision because we can measure the bacteria. We're going to talk a little bit about measuring the bacteria today and how we do that pretty easy. And then the goal is to be preventative, and obviously we're practicing periodontal medicine. So that's somewhat the idea. And we use this graphic in practice a lot to help show our patients, because most people don't understand how tenuous and how, if you can see my cursor around this middle picture here, this is a picture of a tooth. And most people don't understand how hard it is to actually clean the tooth surfaces if what's living on the tooth surfaces is pathogenic. I mean, if you have stuff living on the tooth surface and it's not causing a problem, then it's not so bad. You just have dirty teeth. But if you have bad acting bacteria or pathogenic bacteria here where this cursor's moving around, then it can be very harmful. And to give you a little bit more explanation of what this is a tooth sticking out of the gum, and the pink here is the gum, and the pink is represented in this side picture here by the gum, and the gum has vasculature in it, and it has connective tissue, and this is the gum that lays next to the tooth. And this area right here, Ford, can you see the cursor okay on your view?
I can.
Yeah, this is the pocket. We call this the pocket. And this is that same pocket that if you went to the movies and you ate some popcorn, you got some popcorn stuck down in here. This is that same crevice along the side of the tooth. So this white area here is the tooth. And this brown stuff, this is what we call biofilm, and it sticks, it adheres like tenaciously to the side of the tooth. And you just can't wipe it away with this dental floss alone. You need much more than that. I'll even see if I can make my cursor like a little bit red so you can see here. It might make it a little easier to see. But this area right here, this is where that biofilm sticks to the side of the tooth. And so what happens over time, if you see that pocket, it gets deep and it eats this bone away. And it's your body's reaction to this bacteria that eats that bone away. And so what we like to do is we like to share with our patients, look, this bacteria is really hard to control. I mean, really hard to control. And if we're going to try to get rid of it, we have to come up with a really sophisticated system to do that. And so that's what we do in practice.
You bring up a great point, Doug, about your original point on this. Patients often don't understand why it's hard to clean teeth. This image really helps you see that. Even when you go into the dentist, the part of the teeth that you can see is the easy part.
That's the easy part to clean, yeah.
It's the part that they can't see, which is the danger zone. And like you said, you're never going to get in there with floss. That's just not going to go there. And that's the hygienist and the dentist job, getting down in those pockets and cleaning out that plaque.
Yep.
How hard is that plaque?
And that plaque can be hard. It can be soft, which you can scrape off with your fingernail, but it starts to calcify, a lot like plaque in a vessel. And after a while, it's tenacious. You have to use some special vibratory instruments and things that we have in the practice to get it off. You can't get it off with a toothbrush or a water pick. You have to use something, much more aggressive than that. So we refer to this as biofilm. It's called biofilm. Biofilm grows in your water lines. It grows, it's that slimy algae that can grow in other areas in your fish tank, but it also grows in your mouth. And it's made up of bacteria, yeast, and viruses. And we have studies to show that bacteria, yeast, and viruses also affect the vasculature or the health of the blood vessel. And why we're concerned in dentistry is, we have 60,000 miles of blood vessels and they service our whole body, but namely our heart and our brain. And so for you and I working together, you've made me very aware, keenly aware of how these bacteria affect other systems and how you can have an effect on assessing the vascular disease and brain disease, dementia, and Alzheimer's, and that kind of thing. So in dentistry, we share with our patients about this, about the story that this biofilm does not just stay confined to the pocket. What it does is it penetrates the epithelium, and your doctors know this as the endothelium and inside of a blood vessel. And in fact, it's a direct portal into the vascular system, and it travels around. The traveling oral microbiome moves around the body. And the nice thing is I can do a swish and spit test, very affordable swish and spit test, and I can identify this. And the article that you mentioned that you did another YouTube video on, that article that you mentioned is an article that stresses that these high-risk pathogens, or if these pathogens are determined, like where I'm outlining with my cursor, these high-risk pathogens can actually, now we have a causative, or we know it, we understand it much more than just an associative risk with cardiovascular disease or vascular disease. There's a causative issue there. So
you're right. We've known about the association. It was on billboards 20 years ago with the public health folks. But what we didn't know was, is it causative? In other words, does gingivitis, oral disease, actually cause heart attack and stroke? And again, I think that was the definitive article in that area.
Yeah, and now we know that it does. And the interesting thing, and what we're trying to get our hygienists or our periodontal therapists to do, and what we need them to do, and what the good offices and our Wellness Dentistry Network offices are trained to do, is identify this disease by using a sign of inflammation, one of our cardinal signs of inflammation, which is bleeding. And so we have a calibrated methodology to look around the gums and see who's bleeding. And we measure this every time our patients come in. And we let them know if they have inflammation, we let them know. And then we also wonder in our patient population, for all of our patients, we wonder, even our younger patients, we wonder where they are on their journey with vascular disease. And we know Ford, your profession has provided us some nice tools. The CIMT, the carotid intima media thickness ultrasound, can help us determine their vascular age and if there's plaque. And we now are thinking that if there's anybody that has any sign of plaque, or even if I see a calcification on an x-ray or something like that, I'm very suspicious, and I'll send that patient for a further evaluation, because basically a calcification anywhere in the body that you can pick up on an x-ray or that you can see through ultrasound testing is a sign that patient has disease, and they deserve really aggressive preventative management. So we have our hygiene. Go ahead.
You bring up a good point, and just wanted to make a comment about one of my viewers put a series of comments on the channel, and he heard the term plaque talking about teeth, and he equated it to plaque in the arteries. Well, they're both involved with cardiovascular risk, but they're not the same thing. You want to clarify that for the viewers real quick?
Yeah, our plaque is strictly a conglomeration of bacteria and bacteria byproducts.
And it's on the teeth and the gums.
Yeah, around the teeth and the gums. And so, the plaque is harmful to the because it initiates, I don't think I mentioned it here today, but there's a great paper written by Dr. Schenkind that looked at, it's a review paper of all the literature, 152 references were evaluated, and he identified 97 different papers that talked about how the bacteria, the plaque that I deal with, the bacteria that lives around the teeth, that generates this inflammation that we're looking at in the varying levels of inflammation in this chart, how that plaque creates changes in either lipid values, biomarkers, antibodies, or even certain other blood characteristics that that affect vascular disease. So our plaque is an accumulation of bacteria. I think, Ford, your plaque is lipid rich, and it's made up of other things. And maybe you can say what your plaque is, because we're going to get to that in a minute.
Yeah, we've got several videos on it, and you mentioned CIMT. CIMT measures plaque in the carotid. That's what the C stands for, the artery of the neck. It's where mostly bad cholesterol, soft cholesterol, LDL, gets between the two layers of the artery, the two inner layers, the intima layer or the endothelial layer. Doug mentioned that a couple of times, or the medial layer, or the muscle layer. That's part of the reason, I think, why so many people, the doctors included, medical community, has tended to focus on LDL or what they call bad cholesterol. That's what makes up the plaque. Unfortunately, and that's what this whole channel is about, most people don't understand that inflammation is required before you start getting that deposition of that cholesterol. So again, CIMT, carotid intima media thickness test. It's the same thing as a regular carotid ultrasound, but you actually look at how much plaque has been deposited in that artery. We've got several videos on it.
Yeah, and so we know, Ford, so here's what I'm thinking. When I see a patient with periodontal disease, the first thing I'm wondering is, I wonder if they have vascular disease, and the way we can figure that out, or the way we see that, is by ordering or getting one of these imaging studies. And they're not so easy to get either, but more and more people, I hope, are going to be doing those, the CIMT test, and you can get them different places. But once we know they have that, then we really, really want to make sure we reduce oral inflammation. Because on these patients, like in this picture here, where you see the gum is all full between the teeth, and you don't see black triangles, or you don't see spaces here, this patient said this bleeding is a sign of very early disease. And so we'd like to get and we have our hygiene teams really identifying this line bleeding and making sure that at the earliest sign of seeing this bleeding, we give the patient more tools to figure out how to remove that biofilm at home, and do a great job at home as well as in the office, and so that it doesn't affect the vascular system.
Speaking of that bleeding, Doug, could you go back to that just a second? I wanted to make a comment. I'm a doc that does this kind of stuff for a living, but I was in my 50s. This was less than 10 years ago, actually less than 5 years ago, that I learned that any bleeding when you go to see the doc is bad. I just always thought that was a part of what or when you go to see the dentist, I thought that was a part of what the dentist did. They'd go in and when they checked around, sometimes they would purposefully cause bleeding. I never had a dentist tell me, look, that means you've got inflammation in your gums. And I had bleeding up until, again, just less than 5 years ago. Yeah, my viewers know that I have early prediabetes, and probably have had that for a while. So that's probably been part of what's been going on with me.
Yeah, and part of
Why is it that dentists don't tell you that, Doug?
No, I know, and we have patients that come in just like you, Ford. They think the bleeding's normal, and it's not normal. But I don't think that we as a profession have really understood how hard it is to get the bleeding to stop for some people. And we have to do more for them. We have typically blamed the patient. Oh, you don't brush, your mouth is not clean. That's not what it is. If you have bleeding gums, let me back up. I have patients who don't clean their teeth that well, and they might not have an inflammatory reaction to the plaque that lives around the teeth. So people who have bleeding gums and people who have periodontal disease, I want to make sure they understand it's not a disease of neglect. It's the disease of susceptibility. They're susceptible to the disease and they have it. So we no longer make people feel guilty about that bleeding, because you'll have people come in and they'll say, hey, I'm a bleeder. I know my gums bleed all the time. And we'll say, we know that's normal for you and we know that's how it's been for you, but it's not normal. And we want to give you some tools to see if we can make that go away. And so we have taken the burden off the patient, and we've tried to give the patient more tools to be more successful and just stop making them feel guilty because they're not spending enough time with just a toothbrush. A toothbrush is just one of the simplest things. We have many other things that we can do to make the teeth cleaner and to disrupt and to eliminate that biofilm. So what the goal is for it as we collaborate together is we try to create pieces, and part of the Wellness Dentistry Network, which I think you and I might have talked about off air a little bit. We have 120, over 120 offices. We're only a couple years old, and we have UK, Australia, Canada, United States. These dentists all over the world are interested in making their patients healthier, and we're looking to work with collaborative docs like you, and we have 4 or 5 docs in the network as well, and you being one of the first ones, which I thank you for, because you've been very helpful for me and for my community. We try to create these pieces to help educate patients and make them aware that, hey, there's this relationship. You got this problem in your mouth, and we look at some other risk factors for cardiovascular disease, and we really want you to be evaluated by someone like Ford, who has taken a very preventative approach to cardiovascular disease management, and we're not waiting for you to have a heart attack or a stroke, in order to make you well. And so, Ford, we start to enter into your world because we know the key mechanism behind these oral bacteria is their effect on the vessel. And this is a cutaway from Cleveland Heart Lab, who's really been very encouraging to work with dentists, and they've been really happy to work with us and to help us obtain some of these biomarker tests that I think now you can maybe share with us, or you can kind of take away this part from here.
Sure. So for the viewers, Doug is going to take the next few slides, and I think most of the images are from Cleveland Heart Lab.
They are Cleveland, yep.
There are a couple of labs in the country. There was a lab called Boston Lab that I think I know used to do this. There were a couple of others as well. Cleveland is the major one that I know of at this point. They do provide a series of tests which demonstrate cardiovascular inflammation. Now, I'll get into some rough and tumble politics and community issues for a minute, Doug, if you'll.
Yeah, just be careful, politics. Just be careful.
Before I do, though, I do want to make a statement about this whole issue of trying to evaluate yourself. How do I get evaluated for inflammation? Like I said, not my entire channel, but a lot of my channel is about anything prevention, and it focuses on the baby boomers. We've actually done a couple of pediatric things, a couple of things on history, but most of it deals with the chronic diseases that are killing people today, and that's baby boomers, and it's, as you know, all of them driven by cardiovascular inflammation. It's kidney disease, heart attack, stroke, dementia. We have a major focus on dementia. And again, as you know, all of those are driven by inflammation. You also know about 80% or more of inflammation is driven by prediabetes, diabetes, insulin resistance. Now, we're not going to get into insulin resistance or any of the causes. Again, Doug has done some work to help his dental community, the Wellness Dentistry Network dentists, help their patients become aware of this. They do a couple of things. The first is they actually make a CIMT available to their patients, which we've mentioned already. The other thing they do is offer this blood test for cardiovascular inflammation. Now, here's where it gets into some of the politics. You know, I know when Doug was looking at providing this, he went to other docs within the medical community. A lot of docs were very hesitant and nervous to do it. I think their perspective was, look, these are medical tests.
Yep.
What's a dentist going to do once the dentist finds that? Well, Doug can tell you, and his dentist can tell you, they make the patient aware. And guess what? Patients aren't often going to get something done if they don't know there's a problem. So they make the patient aware, and then they refer them into a doc to get started on that work. Find out what's the cause of that inflammation, and then what do we do next?
Yeah, and Ford, before you continue on, I would say that what gave me the courage to think I had the right to at least ask this question was all this science that linked the gum disease bacteria to cardiovascular disease. And I thought, at one of my dental meetings, a big dental meeting several years ago, they were collecting these inflammatory biomarker, collecting this data, or they were offering this data in the hallway of the dental show. And I thought, if they're offering it in the hallway of the dental show, why couldn't I offer it in my patient, to my patient population? So I contacted an attorney. We created a disclaimer letting people know we're not physicians. I'm not going to manage your vascular disease. I'm going to let you do that, Ford. That's the idea behind the collaboration. But surely, if I could help you identify it and help you understand you have an issue, what's the problem? So it gave me the courage to go ahead and work with Cleveland, which is now partnered up with Quest, to be able to get these biomarkers and get our dental community to start to get this. But to that point, Ford, we need you. I have to refer a patient over to someone like you who understands this to manage the disease. We're not managing it. We're only identifying it.
You're a dentist, I'm a doc, and both of us were having to play lawyer in terms of trying to figure out what's legal or not.
Yeah.
And here's the next perspective. You came to me about that. I wholly support it. And here's my view. Does a trainer or even an administrator at the YMCA know what to do with the high cholesterol test? No. But why does nobody blink an eye when you have these health fairs and they're testing for cholesterol?
Sure.
So it's the same thing. We need to focus on prevention, and it takes communities to do that, not just one ivory tower doc. Ivory tower docs an isolated doc can't handle a whole community. It takes a team. So speaking of communities, one of the issues that we'll get into a little bit deeper later in this discussion is the different communities that are available. For docs, the question is, let's say I get this evaluation, I get this test, I get the CIMT, and maybe as an individual I get the inflammation test and find out that I have it. Where do I go next? Well, there is a community of docs, the Bale-Donine community, Brad Bale, Amy Donine. They're very active, and they've got actually practitioners all over the country now who are focusing on cardiovascular components of this. I'll also make one final comment, and then I'll be quiet for a minute, Doug, and then let you take the podium back. So I am doing a course on cardiovascular inflammation. If it's successful, we'll follow up on causes and things like that. But this actually, the next few minutes that Doug presents these markers will give the viewer an excellent overview of what you'll get from the course and how you can evaluate it yourself. Last comment on that is evaluating it yourself. As I mentioned to you recently, Doug, I've got a partner named John Lorscheider. John was one of these very smart patients that knew that he had challenges here, but he couldn't find docs that knew how to get to the bottom of it with him. He found out that actually you can get a lot of these tests, including this set of tests, as a patient online. You don't have to have a doc. You don't have to be a dentist. So again, you and me, when we were setting this program up originally for the WDN, probably a little bit more worried than we needed to be. The laws out there, for the most part, that we can tell look like you as an individual, not a medical person, as an individual can go to this lab and say, I'd like to have this test done.
Well, that'd be a great, I wasn't aware that people can do it on their own, and I would love to know that, Ford. So I hope you'll provide us with that information, because I have plenty of patients that would do that on their own. As a matter of fact, dentists that are interested in these wellness concepts and what we do in the Wellness Dentistry Network, one of the things we're really big on is providing some bona fide medical metrics that show people, a measurable, some kind of test that shows people that they have an issue. And one of the other things we do in practice is we do home sleep testing. Home sleep testing is something that's easy. A patient can wear a sleep test device home, and many patients will do it in the comfort of their own home, but they won't go to a hospital and have a formal overnight sleep study in a hospital setting. So to that point, many patients, if they could get these lab tests done and direct it themselves, many of them would probably do it versus going to having to seek a different doc or go to a medical facility to do that. So I appreciate that, and I'm looking forward to learning more about that. So the idea behind these inflammatory markers, Ford, that you're an expert on, is that certain markers that happen, this cutaway of this vessel is various stages of vascular disease. And what it shows is that at the various stages of disease, there's significant, some of these biomarkers that are given off. And some of these biomarkers are basically ones that just increase your risk, and other ones kind of let you know that there's some disease activity going on, happening. And so, Ford, I know you focus on maybe one or two less biomarkers than this Cleveland inflammatory panel, but the idea is just to show that some of these biomarkers are low risk indicators, and some of them, are more moderate risk indicators. And I think in this moderate risk indication area, Ford, you're pretty concerned about hsCRP and about microalbumin creatinine ratio, right? These are these two right here. Maybe you comment on that just for a second.
Sure. So actually, I'll go back to some of the comments around community and which communities use what. Brad and Amy and their community use all of these indicators on here. There's a fellow, and they've been teaching they're like the itinerant preachers that have been teaching this for 20 years out there. It was discovered by a fellow named Paul Ridker at Brigham and Women's. It's Harvard, one of the Harvard hospitals. He and a colleague, Gavin Blake, noticed with the Waskoff study, the West of Scotland study, over 20 years ago, and actually even the Framingham studies, that people that had elevated CRP, which it's just a protein made by the liver. It's a response to inflammation. People that had elevations there were at risk for heart attack and stroke. They also noticed, by the way, that even if LDL went up, whether it went up or down, if patients were started on certain statins, they tended to decrease their CRP. They tended to decrease their risk for heart attack and stroke. So that's where this whole issue about maybe the statins work more by inflammation than by LDL. That's where that came from.
Gotcha.
Last, an update on Paul Ridker and his group. They just published the International CANTOS study, where they took a very strong injectable anti-inflammatory called canakinumab, or Alaris. Believe it or not, that decreased heart attack and stroke. The leaders in cardiology all over the world, you can look at the YouTubes and they're saying, I knew that inflammation had something to do with heart attack and stroke, but this study just caught me flat-footed. I did not know that you could prevent heart attack and stroke with that. So it's like, duh. But it was very confirmatory for this whole process of prevention through managing inflammation. As you and I've talked, the two that I really focus on are this CRP, which Ridker and his group uses, but also MACR, microalbumin creatinine ratio. And actually, most docs, even in standard practice, do focus on that because they know that it's a strong indicator of how well your kidneys filter is working. If there's protein spilling through that filter, then there's something wrong with the filter. There's holes in it. And guess what? The filter of the kidneys is made from the intima. So if there's holes in your kidneys filter, there's holes in your intima.
In your vascular. Okay.
And that's what we're looking for, holes in that intima.
Yeah. So Ford, from a standpoint of going back to the inflammation thing a little bit, the CANTOS study, that would really, that totally plays into why we're so concerned about oral inflammation, right? Oral inflammation as a driver of whole body inflammation. We know there's this cascade, and I think toward the end of the presentation, I'm going to show the current model of periodontal disease progression, but it's the biofilm around the teeth that initiates that whole cytokine and that whole inflammatory cascade. And so that's why these mouth issues start to affect this biofilm. So I can use that CANTOS study as a really good thing to help my docs understand that inflammation is the driver of heart attacks and strokes, not just lipids, right? Is that the idea?
Oh, yes. In fact, inflammation is much more a driver than LDL. The LDL, what everybody knows of as bad cholesterol, actually is significantly involved. It's the driver in some people that have genetic problems, familial hypercholesterolemia. But for most of us, it's not the LDL, it's this.
Yeah, great. And then, so here's your urinary microalbumin ratio, and you already explained that beautifully about how the kidney filter and the intima media or the intima filter are similar. And then as we get further into the disease progression, other biomarkers are even associated with higher risk. And I know, Ford, you're going to explain this, but just interesting on this LP-PLA2, I was in 2005 at University of Michigan. My professor who taught us the microbiology of periodontal disease and of cavities, he was looking at, even in 2005, this is well over 15 years ago now, LP-PLA2 and how LP-PLA2 could be changed if periodontal disease were treated. And he noticed about a 10% reduction in LP-PLA2 in people that had periodontal disease treated to a stable clinical endpoint. So this information is not new, but again, it takes years to get out into the dental profession. And so we're very, very stringent about making sure our patients don't have active periodontal disease. And any of our Wellness Dentistry Network member dentists should know how to do that, because it even affects one of the higher risk measurables, LP-PLA2.
Yeah. So just another plug for the course that John and I will be releasing on how to understand whether or not you have inflammation. It's a digital course. You can find it on our website. And we focus on four studies. The CRP that we talked about, that Ridker and his group use all the time. The microalbumin creatinine ratio, which shows the status of your endothelium and how your kidney filter is working. Doug, you just mentioned MPO and plaque and LP-PLA2. Those are both enzymes. If you look at this picture, actually the little green dots represent MPO. MPO, myeloperoxidase, is something that Brad and Amy in their book, Beat the Heart Attack Gene, call the Joker. It's a very dangerous one. As I mentioned, like plaque-2, it's an enzyme released by immune cells. Plaque-2 is also an enzyme released by immune cells. And again, this gets back to some of the common misunderstanding of what we mean by inflammation. People often they hear plaque, they understand that plaque is bad cholesterol, and they know that their docs are looking for plaque and bad cholesterol, but they don't get the inflammation piece. Well, regular cholesterol is a waxy, stable substance. As you see on this picture, it can get unstable, liquefied, and if that liquid goes out into the bloodstream, it will cause a clot. Well, here's how it gets liquefied. These two enzymes, the plaque-2 that you just mentioned and the MPO. That's exactly their job, dissolve that plaque.
So when we see, I know when I do some of these tests for patients, I tell them, especially if they have one of these really elevated, we know the MPO can be a test that has quite a few, it can have some false positives with it. So we have to be careful. But if these patients have any of these things that are highly elevated, Ford, I really want them to get them to somebody like you. And then if everything else in their life is like going really, really well, or it seems like it's going really great, and they have just one of these enzymes that's really, really elevated, don't you two just advise to redo the test? I mean, just to check it.
So here's the problem with MPO. In their book, Brad and Amy call it the Joker, and they make the point that everything else could be okay, but if MPO is elevated, all bets are off. Well, that sets up a significant problem, especially when you consider that of these tests, MPO is by far the most common test to have a false positive. And I could get into the details in it, and actually I do on the course. But I've often had to talk patients back down out of a tree when they were very concerned after reading that and having a single lone positive MPO. Don't panic. We'll just take some simple over-the-counter melatonin and retest again. And we can get into some of the details. I do get in some of the details on our course.
Great. Yep, and then this is again, the myeloperoxidase piece. So what's happened in dentistry and what we've been able to do, Ford, with your help, and you helped me put this together, is we do have a very affordable panel that dentists can order as a screening tool. Again, we have a disclaimer that we have our patients sign that lets them know that we're not physicians, we're not treating this, but what we're trying to do is get this information for them so that they can learn about their inflammation. They can and they start to relate their oral inflammation as well with their overall whole body inflammation. And when you see the word, and why we called it wellness dentistry, is because we have this chair time with patients, just 45, 50 minutes with patients, and many of the other things that you talk about, smoking and exercise and nutrition and exposure to pollutants and supplementation and all these other areas of lifestyle, we can start to dribble in conversations. Sleep quality and sleep quantity. We can start to dribble in conversations in our patients to start to create awareness that helps them even be better at managing their vascular disease when they work with docs like you, so that they know, they understand the importance. And so what this sets up is a very, very supportive collaboration between guys like you and guys like me and gals like our Wellness Dentistry Network gals and gal physicians. It's just it's really a great opportunity. And once you have this informed patient, I mean, they really want to be healthy in other ways. They want to learn about other things. And we hope we can be the premier network of how to create the tools to allow that to happen. And we have a Partners in Health page as well in our network. And we're trying to put these people together. And as you know, Ford, these relationships are just evolving. I mean, there's not many around the country that are really, really working great right now. And our job, my job and your job, we're going to figure out a way to make that a lot easier for people. And so I appreciate that. So this lab panel is something that dentists can do. I'm recommending that they should do after taking some coursework and understanding it, something they should do. But Ford, you've informed me that, in fact, our patients, if they are aware, they can get this and they can do this on their own, and then we can help them, find people like you. So that's the idea. So to summarize, it starts. This is a summary of, we call it the current model of gum disease. Periodontal gum. Current model of gum disease progression, and it always starts with a microbial challenge. in this microbial challenge we need to be aware is yeast, viruses, and bacteria. And that microbial challenge initiates some response. This is this yellow box. It's called this host immunoinflammatory response. And this is a very significant personalized response. It's made up of how you live, your environmental risk factors, how much sleep you get, how you eat, exercise, all that stuff, alcohol consumption, everything, and the innate risk factors. These innate risk factors are genetic risk factors, like how you're born. As I said earlier in this discussion, we don't blame patients anymore for having periodontal disease. We know some are highly susceptible, so we always ask about a family history. And I think in the cardiovascular world, the family history and the genetics of the disease are also significantly important. And that's why Brad and Amy's book is called, Beat the Heart Attack Gene. It's a significant piece. And if this host immunoinflammatory response becomes dysregulated and the immune system can't shut down the inflammation, we have much, much increased risk of cardiovascular disease, and we have a huge risk of further bone and tissue destruction in the mouth that creates problems for the teeth. Now, as a physician, you would see this if the patient really got far down the road in the disease process. You would see maybe flaring of teeth, you would see spaces around the teeth, patients would have notoriously bad breath. There's a lot of things that you would notice as a doc, but when you're looking at people that have gum tissue that looks relatively normal, there's years, just like pre-diabetes, there's years that disease has been present before it starts to show up visually like that. So that's what we're trying to do. We're trying to train docs to be able to find that much, much earlier and then treat it to a much more succinct endpoint. And why I brought this in here, even though it's a little bit of a confusing picture, is the story is very similar to how vascular disease happens. And in that Dr. Schenkein review paper, he showed 97 different papers, again, that showed how just the things that make up the challenge in this box, the bacteria, how it affects these blood lipids and biomarkers and blood characteristics and antibodies that drive this system. So it's very complex, and we're understanding it much more. And in fact, it's so complex, we came up with a very stout, detailed protocol that we share with our member dentists on how to rid the mouth, how to shift the biofilm, how to learn about the pathogenicity of the biofilm. That's how aggressive it is. How we learn about that, and then what we have to do to get it under control without blaming the patient, and without making the patient feel like it's their fault. We provide them the tools to do that. And when we get the patient stable for it, it's very interesting. What I learned is that in school, even Walter Loesch taught me that about 6 weeks after I did the in-office debridement, the very detailed, torturous removal of the bacteria around the teeth, that in 6 weeks the patient should really be better. Well, when I started to measure biofilms and look at how long it takes to get the biofilm to actually shift to a healthy biofilm, it takes about 4.5 months in my hands. So it's a much, much different, it's going to reshape how dentistry thinks about what it is that we're doing. And I can tell you, if you focus just on the teeth and you just scale the teeth and you don't think about removing the biofilm and affecting the biofilm in the whole mouth, and then joining with someone like you and affecting, what's going on in the body, these two are working so closely together that as we work together, we have more and more success. So that's really the key. But I've learned some fascinating things looking at this biofilm. And I know we'll have some further dialogue, but I can have a healthy mouth, and I can get a cold, or I can have a virus, or I can be sick in some other way. But here's what I've learned as a dentist, and here's what I've learned from working with guys like you. If your mouth is sick, there's going to be some health effect somewhere that's preventing you from being as healthy as you can be. That's for sure. So our goal is to make sure people walk out of our practice if you said to me, if we're getting on an elevator in a hotel and you said, hey, tell me what a Wellness Dentistry Network member dentist and physician are, and I would say we are healthcare professionals that have a keen awareness about how oral conditions and mouth stuff affect systemic health. And you're on the physician side, it's vice versa. And we need each other. And Ford, I hope we can make it our goal to knit these professional networks together in a way that we can create healthier patients, and we can stave off some of these diseases, and we can greatly reduce medical expenses and unnecessary hospital experiences. That's really what we're trying to do.
So, Doug, you bring up a couple of good points for wrap up. When you think about it, this process is the major killer for most Americans as well as people throughout the country, the world. Heart attack, still the #1 killer. Stroke, used to be the #3 killer. Now it's closer to #5, but it's still the #1 disabler. This process is critical to dementia and Alzheimer's. So it's the big issue behind kidney disease. So you start looking at all these diseases and disablers, and you start thinking about, well, if this is the #1 cause, how do I find out? Again, you read, you look, we've got several videos on our channel. Doug has formed this network of dentists who help their patients get focused on it. Again, I'm developing a course with John. You can look at that course.
That'll be available to us too, right, Ford? We can, some dentists should be watching, correct?
Absolutely. Well, it'll be coming out, I'm guessing about 3 to 4 weeks. I've done the videos now. There's several videos which go into detail regarding the science of each of those inflammatory markers. Then John, as I mentioned to you before, John's a great resource here. He goes into detail on how he went ahead and got these before he even knew a doc. He's open that he's been a patient of mine for a couple of years, but before he knew me, he was able to get access to these kind of labs. And he's going to tell you in a video and some text and forms exactly how you can get that done. Beautiful. So, well, assuming these are successful, then we plan to do more courses on what causes it, how to prevent it, things like that. But that's just the way to get started. Now, here's one other point. Speaking of communities, routinely will get docs writing into my channel asking how they can get training from me. Routinely, I will refer them to Brad and Amy and their community. But as you know, that takes a whole weekend, and it's expensive for a lot of docs. So right now, if you're a patient and you want to meet with a doc who knows this stuff, #1, ask your own doc, because there's nothing like working with your own doc. He or she's got decades of experience and they know you. But if your doc doesn't want to get there, they can get trained with Brad and Amy. Meanwhile, I'm working on some training myself. So I'll be working further with Doug and the Wellness Dentistry Network to help with the physician component of that.
Yeah, and forward to that point, I've been around the Bale-Donine community and the Bale-Donine methodology for a number of years now. I've attended several of the preceptorship courses myself, and I'm involved in that community. And I recommend it for the dentist as well as a hygienist, anybody that's willing to take the time to go, because it does really open your eyes. And there is a new wave of healthcare practitioner out there that's going to, that can really make a significant difference. And I would say this is another thing that I share with my patients. Detecting disease late is really easy. I mean, easy to know you have heart disease when you have a heart attack. And it's hard to fix. But detecting disease early is hard. And it takes some biomarkers, it takes some labs, it takes a little bit like that. But you know what the beauty is? When you detect it early like that, fixing it can be really easy, or stabilizing it can be easy. So Ford, I can't thank you enough for all that you do for disease prevention I hope that together we can really create some dynamic duos out there, because each of our practices, each of our practices treat, in dental practices, we usually see 1,500 to 3,000 patients, and boy, what a difference we can make. So Ford, thank you so much for taking the time today to allow me to be a guest and to help you with your journey as you helped me with mine.
Thank you again, Doug.
All right, bye-bye now.
Bye-bye.